The broadcast is now starting. All attendees are in listen-only mode.
All right, good afternoon. Welcome to our webinar, Improving Accountable Care Requirements for Population Health Management. I'm Keith Blankenship, Vice President of Technical Solutions with Lumeris, who is sponsoring this webinar. Lumeris chose to sponsor this research because we are passionate about helping healthcare systems, payers, and providers transition from volume to value-based care. And we are watching our clients as they face living in two conflicting worlds, the fee-for-service world and the value-based healthcare world. This dichotomy will continue until reimbursement models catch up and healthcare makes a decided shift toward value. The research from IDC Health Insights provides a framework to prepare healthcare delivery systems for the evolution to population health management and a healthcare system that focuses on balancing the priorities of the triple aim. Those triple aim points being improving the patient experience of care, including both quality and satisfaction, improving the health of populations, and then finally reducing the per capita cost of healthcare. With that in mind, I'd like to introduce our presenter, IDC Health Insights Research Director, Cynthia Burghard. As a research director, Cynthia's passion is to provide the intelligence needed to manage the business and quality of healthcare. She has pioneered the use of healthcare information, including building healthcare data warehouses at both the local and national level, as well as developing and implementing analytics for employers, health insurance managers, physicians, hospitals, and government agencies. Prior to joining IDC Health Insights, Cynthia served as a Senior Vice President at ICA Systems, a premier provider of enterprise-level cloud computing technologies for commercial, Medicare, and Medicaid health plans, where some of her work resulted in award-winning client case studies. We're thrilled to have Cynthia with us today, presenting research that, as I mentioned earlier, is very important to Lumeris and our clients. A little bit about the presentation. It's going to last approximately 1 hour, and it's going to cover the new requirements for population health management, as well as IDC Health Insights Accountable Care Maturity Model. At the end of the presentation, Cynthia and I are going to discuss some current tools and processes that are showing a very strong return on investment. After that, we will then take some time to take questions from you. So at this point, I will hand the microphone over to Cynthia.
Thank you, Keith, and good morning, good afternoon, good evening to everyone. Thanks for joining us today. A little bit of housekeeping. There is a box on the right-hand side of your screen that says questions. As you think of questions, just type them in there, and then as Keith mentioned, towards the end of the presentation, we will answer those that we're able to. When I talk about population health and I talk about accountable care, I view it as a journey. And the challenge, of course, is that journey doesn't have a GPS. There's no yellow brick road. There are no instructions on how to get from one stage to the other. We've done a bit of work on that at IDC by creating maturity models, but each organization is different. And one of my recommendations to clients are, get in there, fail fast, fail often. We're going to go over a couple of things today. First, I'm going to give you a perspective on where we are with accountable care, where we're going. We'll talk about the maturity model and an issue that I think is really critical, which is about the sustainability of accountable care and population health management. And then we'll talk a little bit about how you begin this journey. Where do you start? So let's take a look at some of the accountable care initiatives in the market and how well penetrated they really are. There are over 5,000 certified NCQA patient-centered medical homes. We did a survey about 18 months ago, and 71% of the healthcare organizations that were surveyed, and that included 40 hospitals and 30 health plans. 71% of them were involved in a patient-centered medical home. And that intuitively makes sense to me because the patient-centered medical home was developed by providers. So it's very consistent with how they want to practice on becoming their own objectives. If you take a look at the CMS programs, there are over 200 shared savings organizations participating in shared savings. And I think that number just went up. There are 23 pioneer programs. And again, in our survey, 34% of organizations were involved in shared savings and 6% in Pioneer. One of the things that we noticed as a result of this survey is organizations are involved in multiple accountable care programs and initiatives. So organizations may be sponsoring patient-centered medical homes or participating in them. They may also have a Pioneer program. And so I think it's an example of early stage of a market and organizations trying to kind of figure out where they stand, if you will, in this new world. And then finally, there are hundreds of fee-for-service programs with quality upside risk. Here in Massachusetts, where I'm located, Blue Cross Blue Shield, about 5 years ago, I think, started a program called the Alternative Quality Contract, where they're paying fee-for-service with upside bonuses for quality. And I just recently saw some of their results. And keep in mind, they've been at this for about 5 years. Lots of good process improvements, more screenings, more preventive visits, and so forth. And they're just starting to see some real improvements in the clinical outcomes of their patients. So they're seeing reduced blood pressure. They're seeing stabilization of and participation in A1Cs. So we're really beginning to see that needle kind of move a bit. I often get asked why I'm so bullish on accountable care and kind of these new models. And I think it's about two things. One is about collaboration, and the second is about the data. And if we look at the next slide, it talks a little bit about some of the results of our survey. Oh, sorry. I confused myself. I apologize. Okay, so here are some of the successes that we've seen. In year one, there were almost 700,000 beneficiaries in the Pioneer program. Their growth of cost was about 0.3% versus 0.8% in non-Pioneer programs. 13 organizations produced gross savings of $87.6 million. I think the net savings was somewhere around $75 million. And 25 of the 23 ACOs generated lower risk-adjusted readmission rates. I also took an example from Capital Health Plan, and these results are from their patient-centered home initiatives. So at Capital Health, what we saw was inpatient stays being reduced by 40%, ER visits by 37%, and healthcare costs in general by about 18%. And while these are terrific results and a good sign of continued improvements, they really represent what I would call low-hanging fruit. So keeping people out of the emergency room, diverting them, looking more carefully at inpatient stays. We also, many organizations are also seeing significant reductions in their readmission rates, and that's really driven by Medicare's penalty system, if you will. So this is where I start getting a little bit anxious that we need to move beyond some of these process and structure methods and approaches and really get into what's going to take to sustain clinical improvements. And that's really where we're going in terms of kind of the next stage of accountable care. What I was mentioning earlier when I was confused about the slides is I often get asked, why is accountable care going to work now? I was in the 70s or 80s, I guess it was, and capitation didn't work, withholds didn't work, and I think it's really about two initiatives. One is about collaboration. Back in the 90s, 80s and 90s, when we were introducing managed care, the payers really just wrote their contracts, put them in front of the providers, and surprisingly, the providers just signed them. There was no real sense of whether this was doable. Very little data was involved. Today, what we see are healthcare payers and health care providers, sitting down and agreeing beforehand, what are the metrics that we're going to measure by? How do we define those metrics? What kind of data are going to be involved? And that's really the next issue, I think, that is going to make a lot of difference, which is we now have data. Back in the 80s and 90s, we started a program, a capitation program, and at the end of the year, maybe at mid-year if you were lucky, the data would come back to the provider saying they had overspent their budget or they weren't going to get their withholds back. And that not only created a tremendous amount of hostility, it really didn't improve care that much. At one point in my career, I was doing employer group reporting, and it was just after managed care had been introduced, and the employers were really wanted to know what they were getting in terms of improvement, and we had a really hard time showing that improvement. And I think part of it was there were no data, there were no guardrails, and there was really no collaboration, if you will. So I want to talk a little bit about the maturity model that we developed at IDC. IDC built a framework, and I have applied it to accountable care. The first stage is the ad hoc stage. And this is really when there are pilot programs, there's proof of concept, really no staffing, dedicated staffing anyway, no new technology, really just dipping toes in the water. The next stage is the opportunistic stage. And that's the stage where if someone brings a program to me as a provider, I'm willing to sign it. But I'm not actively going out and making changes to my organization or in my outreach to actively market, if you will, my accountable care programs. The repeatable stage is the third stage. And in this stage, as one would guess, it's about taking what you've learned in the first two phases and applying them across an enterprise. So it's really about saying, okay, here's some processes, here's some data, here's some technology. Let's replicate that across the enterprise. So it's beginning kind of the enterprise-wide deployment. And then fourth stage is the managed stage. And this is a stage where there are dedicated resources, there's a budget, there's a corporate recognition that this is really the way an organization should move. There's investment in more technology, both from a applications point of view as well as from an infrastructure point of view. There are people that have dedicated responsibilities in accountable care and accountabilities for their programs. It's moved from maybe a handful of diseases to a much broader sense of distribution across disease cases. And then finally, there's the optimized stage. The optimized stage is where everything is in place. The organization has made a transformation from volume to value. The corporation recognizes and embraces the level of change that they've gone through. And it's really kind of the fine-tuning, if you will, of people, processes, data, and technology. And for each of those stages, we looked at 5 different sets of measures. There's the data, which is about creating relevant quality data, access, sort of role-based access, if you will, to the data. And it's about access to new sources of data. I think that's probably one of the most exciting pieces of it. It's really, it's moving outside of working with the structured clinical and financial data that we typically have. In terms of processes, it's about enterprise-wide adoption of best practices. It's about conducting health services research and really evaluating your programs, being able to, and it happens in a continuous fashion, I would argue, but it's really about identifying the best way to treat certain kinds of populations. And from a technology point of view, as I mentioned earlier, it's about infrastructure. Virtually all of the suppliers in the population health management market have cloud-based applications or cloud-based infrastructure. The foundational applications are in place. So for health plans, it's the claim system, it's the care management, it's the analytics. For providers, it's the electronic health record. It's the admission, discharge, and transfer, the lab systems, the radiology, and so forth. And then finally, this is really where we begin to introduce the whole notion of population health management applications. Those are the specific set of applications that are designed to help manage populations of patients, both at an individual level as well as at a larger scale, kind of campaign-based. It's about people. Most healthcare organizations don't have people with advanced analytic skills, so those are really required. It's about restructuring the way the care is delivered so that clinicians are really practicing at the top of their license so that we can have the best skilled person in front of the right patients. With the shortage of primary care physicians and the addition of newly insured individuals, we know that there is going to be a huge challenge and access will become an issue. Bringing in physician extenders is going to be absolutely critical to managing these populations. It's about creating team-based care. It's about perhaps if you have a large population of diabetics and people with high blood pressure and people with high cholesterol, that it makes sense for you to hire a nutritionist to work with those populations. It's about embedded care managers, people whose job it is to manage those populations and those individual patients. It's also about the navigators. I think virtually all of the organizations involved in accountable care that I'm aware of have some form of post-discharge navigators. And these are the folks that are following up post-discharge and making sure people understand their medication and that their wounds are healing if they've had surgery, that they've made the appointment for their follow-up care. Done largely to keep people from returning to the hospital, but if you've ever been hospitalized, the lack of clarity that you have as you get discharged is really pretty significant. So for each of these stages and measurements, we've actually created a maturity model that says for data, for example, this is what happens in ad hoc, and this is what happens further on. I did miss the fifth measurement, and that's really intent. So that's about vision for the business. It's about strategy. It's about the healthcare organization having budget and staffing. And it's also about the degree of risk and organizations are willing to take on, and then sort of proactive coordinated care. So I took this model, and the published paper actually has a lot of detailed information about how to move through these various stages. So I took a look at the maturity model and the data that we've collected on participation in accountable care. For example, we know that Levitt Partners has estimated there are about 450 accountable care organizations. There are far more patient-centered medical homes and other programs as well. So for 2013, 2014, we estimate that about 60% of healthcare organizations are at the ad hoc and opportunistic stage. A few more in repeatable, couple in managed, and really no one reaching the optimized stage at this point. Within the next 5 years, we believe that everyone will have moved through the ad hoc stage, and the biggest volume is going to be between the opportunistic, repeatable, and managed stages. So you can see the growth, and as I talk to clients anecdotally, you know, they get the fact that it's a journey. I think what's been really confusing to them is, so what do I do next? And that's what this maturity model has really set out to do, is to help create a framework against which organizations can really map their progress. So let's talk a bit about sustainability. As I mentioned earlier, most of the savings has been around structure or around process, and we really need to get to the whole notion of clinical improvement. Is my blood pressure dropping? Am I staying out of the emergency room? And I think in order for healthcare organizations to really sustain their successes and those getting involved in accountable care, there really are sort of 5 key areas that need to be taken into consideration. One is about business model transformation. Because I'm a technology analyst, everyone thinks all I want to talk about is technology, and certainly I enjoy that. But with accountable care, that transition, as Keith was saying earlier, between volume versus value is really significant. And I actually think getting involved in accountable care is really more of a change management story than almost anything else. And organizations have to kind of figure out the degree to which what the pace is that they want to go through to transform their organization. Talk a bit about more on that. In terms of right partners, no organization can go it alone. It requires domain expertise from both payers and providers, and also creation of networks of physicians as well. The last three are really what's involved in population health management. So that's really about clinical improvement. It's really going after that really hard nut. It's about patient engagement. While we as an industry have spent a lot of time talking about and attempting patient engagement, it's really pretty much a blunt instrument today. There is research being done by organizations like Covisint and Milliman are jointly putting together an assessment tool that will allow them to really identify where the true opportunities exist, where you really can reach savings. I think one of the challenges that we've had is we treat all diabetics in the same stage as alike. And in fact, we know that they're not alike, that in fact they may well have other drivers of their health or disease that need to be addressed. So I think this is an area that's really, while we've been at it for a while, really is going to require a lot of investment, both in terms of understanding what's going to change behavior, who's willing to change their behavior, and how do you communicate that. Physician engagement is the third of these characteristics, if you will. And here it's about helping providers practice differently. I think one of the most effective ways I've seen physicians get engaged is through the use of data. Sometimes it's not always a positive relationship in the beginning. When you show physicians their data and they vigorously tell you how incorrect and inaccurate it is because they know that they check the feet of all their diabetics. Well, they didn't document it. So without documentation, we don't know that. And the whole notion of connecting the results of poor documentation to performance measurement, I think is really a new concept for providers. And in fact, what you see is once the physicians trust the data, they get very engaged. I had the opportunity this summer to speak to a number of users of population health management, and I was talking to physicians, and bar none, their enthusiasm was really due to the fact that they were getting access to data that they've never seen, that can be used at the point of care, and really can help them better participate and provide, really frankly, better care. So let's talk a little bit more about business model transformation. We talked a little bit about volume to value, which is really about how the organization is governed and staffed. It's both cash flow and budgeting. And I think that's going to be one of the greatest challenges as the mix of dollars moves from what's now about 20% of hospital dollars being under risk to a much larger percentage, that cash flow can become an issue, and really how do you budget and how do you model that so you really know what you're getting into. It's about realigning incentives. You know, that's always been one of the challenges in healthcare, which is patients don't pay the bill, so what's their incentive to be cost effective? And they tend to listen to their neighbors about the quality of their providers. So realigning those incentives for patients, for providers, is really going to be a critical part of that transformation. And it's about new referral networks. I think most referrals today are because a physician is always referred to that specialist. Getting an understanding of the implications of that referral, both financially and from a quality perspective, are likely to reconfigure provider networks, particularly as more information and more history is available to help us understand that. It's about care teams. It's about having the accountability to proactively manage health, not just disease. It's about having clear roles and responsibilities. When you change the way an organization has functioned from years, the roles and responsibilities can get very confusing. And I think it's really important to make sure that we understand those and we really spend the time up front, and also continue to reevaluate the roles and responsibilities. And as I said earlier, it's also about practicing at the top of their license. It's about having the right person, the right set of skills in front of the patient. It's also about embedded care managers. And here I think it's even more important that the roles and responsibilities be clear, because you're adding another clinician into an environment, and they are doing things that that environment has not done in the past. And so the relationship between the care managers and the clinicians delivering care really needs to be well understood, and policies and procedures really have to be developed. It's about having the analytics so that those care managers can prioritize and continue to monitor their patients, can find out who else needs assistance and support. It's about the adoption of care paths, and not just who's in the hospital and who's not, but really, a newly diagnosed diabetic who's not insulin dependent, what's the best treatment for them? So really understanding and matching, if you will, the requirements of individual patients or populations of patients to the right care path. It's also about patient engagement. It's about the relationship between those care managers and their patients. One of the anecdotes I recently heard was about patient engagement was there was an individual who was not compliant with the medication, and in order to get him compliant, they had a nurse call him every morning at 9 o'clock and ask him whether he'd taken his medication. Lo and behold, he became much more compliant, and when he was asked about it, he said, I don't want to disappoint my nurse. She calls me every morning. I can't, my responsibility is to take my medication. And I think that's a good example of the variation and creativity that we need to come up with to get patients more engaged and to get behavior changed. So, pardon me. So the whole notion of patient engagement and how and where and when is going to be really a part of this business model transformation. Let's talk a bit about partnerships. Back in the day, we often said, there were partnerships between payers and providers. And I think all that really meant is they had each other's telephone numbers. When sitting down with a partner or a potential partner, it's really important to have clear and shared expectations, really an understanding of how both organizations are going to win. And it's not one organization dominating that conversation. Again, it's sort of about these clearly defined roles and responsibilities. It's about evaluating your own skill set and taking a look at what skills you have versus what skills you need, a gap analysis, if you will. And really understanding where you're going to get those skills and how they're going to work, the two organizations are going to work together. Routine communications is really critical. As I said back in the day, there was really two conversations, one when the contract was signed and one when the end of the year came. With a partnership, you need to have routine communication. Things are going to come up. Issues are going to get raised. Problems are going to be identified. And having regular communication just helps to solve them before they become unsurmountable. Organizations have to be held accountable. There need to be performance measurements, really making sure that each partner is doing what they said they would do, and there needs to be mutual respect. One of the challenges in the 90s, I think, was that payers and providers did not respect one another. The providers thought the payers were just trying to make money off their backs, and the payers just thought providers were sending in bills so they could get paid. And there was no real respect for the capabilities that each organization brings to the table. And that has changed significantly, I think. So let's talk a little bit about the pillars for success. as I said earlier, part of the sustainability issue is making sure that the foundational applications are in place. There needs to be a way to move data from place to place. There are formal health information exchanges. There are also informal ones that don't meet all of the criteria but still create the same end game. And then sitting on top of that are really the population health management applications. Those applications that are focused specifically on kind of AAA, if you will, capability. So it's about improving the experience of the patient. It's about managing the quality of care. It's about managing the cost of care. It's about managing the health in addition to the disease of a population. I was at HIMSS last year, and in fact, virtually every one of the 1,000 booths at the exhibit hall had population health management as part of their definition of who they were. It was all on their signage. And it was everything from the EHR vendors to the ERP vendors to the analytics vendors. And so I undertook the challenge of identifying what the key pieces of population health management were. And there really are three distinct sets of functionality that we need to look at. The first is the analytics, so the ability to not only identify individuals, but do performance measurement, be able to monitor the progress of organizations. The workflow, the creation of and the management of care paths, and then finally really patient engagement. I've done a lot of detailed research about the suppliers in this particular market. So let's talk a little bit about what kind of the analytic requirements are and what differentiators are there, if you will. So it's really about, for analytics, identifying and stratifying patients. It's about performance measurement. It requires at least one source of data. Most of the suppliers are using claims plus clinical data. You need to auto-populate queues based on results and rules. So if I meet certain sets of criteria, I get populated into a workflow tool, and my case is assigned to a nurse, and you want to auto-populate those. And it's also about deploying standard risk methods. Many suppliers have their own proprietary methods, and most of them have been really well vetted. But there's something about saying, this is an industry standard, so let's start here, or at least making that available to clients. In terms of the differentiators here, it's really about organizations that have started to access or provide access to unstructured data. Really important in of the unstructured data. There was an example of Seton Hall Family Health down in Texas, where they used the unstructured clinical data to identify the drivers of readmissions for congestive heart failure. And what they found were the drivers were alcohol use, drug use, and living situation. And they couldn't have gotten that out of the structured data. It came out of the nurse's notes or the doctor's notes. And the more we expand the data sources, the greater our ability to be more precise. Another differentiator is being able to look at both inpatient and outpatient. I think when you talk about analytics for population health management, a lot of the focus is on chronic illness, so it's in the ambulatory setting. We're seeing a lot of inpatient cases also be managed more actively and be able to really get better quality. Part of that is about readmissions, but part of it is just also about the flow of data within the hospital. Let's talk a little bit about workflow and care plans. In terms of the requirements, it's about creating, embedding, and managing care plans, both at a patient level as well as sort of a campaign level. It's about queuing and task management and auto-assignment, sort of classic workflow tools. And it's also about the auto-assignment I mentioned and the campaign creation. So it's really, what are the processes that you're going to use to get from the beginning of enrolling a patient to their ongoing support. One of the key differentiators, I think, in this segment is around electronic health record integration. It's about providing data at the point of care so physicians can make better decisions. There are some vendors that have done that integration, and it's on the roadmap for virtually all of the vendors. Let's talk a bit about patient engagement. The requirements are really about multi-channel communications and collaborations. Today, most of that is occurring either by letter, telephone, or patient portal. One of the challenges I think we've had with patient engagement is we made the patients come to us. Wasn't part of the, we didn't make patient engagement part of their life. We made it as an extra to do. And I think that's one of the reasons that the patient portals have not been well adopted. It's add one more set of tasks, if you will, to a busy person's life. It's also about individual communications and campaign management. So it's both about communicating with me as a patient with a unique set of issues, as well as being able to do broadcast campaigns like, here are the holiday recipes for diabetics. The differentiators are really around secure email and texting. A couple of vendors have this, not widely adopted. I think there's a lot of angst about the personal health information and really making sure that is secure. There's also, outside of these requirements and differentiators, there's a lot of work being done to improve patient engagement. I mentioned a few earlier. There really is a concerted effort to research and collect as much data as you can to make that patient engagement successful and bring the kind of outcomes. So where do you start in all of this? You know, where does the journey begin, and what are some of the key areas that you need to focus on as you move forward? So let's talk a bit about the population health journey. Oh, I keep confusing my slides. Let's talk about the community view of health. Typically, we've thought of health as both clinical and financial, and really bonded or encased in the sites of delivery. What we're finding out more and more are that the drivers of health and disease are far and above their clinical condition. So it's about educating, it's about compliance, about activities of daily living, what kind of family support are available. And moving kind of outside the ring, it's also things like housekeeping, house cleaning. An asthmatic was reporting regularly to the emergency room for exacerbations of his symptoms. And after a bit, they discovered that his apartment was full of mold and dust. They sent in a professional cleaner, and the individual's asthma stabilized. So again, both the Medicare and Medicaid HMOs have become very good at finding some of these outside drivers. If I have to take 3 buses and walk 10 blocks to get to my doctor's, likelihood is I'm not going to go for my follow-up visits. But if someone provides me transportation, I'm right there. If someone, organization, waives my copay so I can now afford my medication, I'll take my medication every day. I won't split pills. We talk about this at IDC as the community view of health, and really it's very similar to the way health is delivered across the rest of the world, frankly. It's really much more of a community based concept. And I think more and more, again, getting back to this notion of sustainability and clinical improvement, we're going to have to learn how to identify some of these drivers and address them outside of the kind of four walls of the clinical and financial. Now we can talk about the healthcare journey. So, you know, where do you start and how do you move? Every organization is different. I put a couple of spots down in terms of how you can get started on this journey. It's really critical to have organizational buy-in. Without that, all the efforts in the world are not going to really bring you great results. We talked about evaluating the gaps in domain expertise and developing a strategy to gain that expertise. It's about understanding your data. We've been putting data into electronic health records for years, not really using a lot of it outside of a transactional thing. You know, as someone I was speaking to this summer was mentioning to me was if the field that you're trying to pull off of this is smoking status, what does other mean? No one really, some thought it meant they did smoke, some thought they didn't smoke. So really understanding the data and what you need to do to mitigate whatever problems you identify, and really setting up kind of the rules. I think it's really critical to start with low-hanging fruit. Why not? It works. One of the really difficult parts of this population health journey are prioritizing who to manage and determining who's going to get personal attention, who's going to get more of a technology approach. At least start understanding the prevalent high-cost cases and where an intervention will make a difference. Some of the advice that I've received from organizations who've deployed population health are start with 1 or 2 diseases or 1 or 2 programs. Don't start with 10. It takes a while to really understand and develop the processes, so do it with a manageable number of patients. You obviously need to, once you've decided what those program strategies are going to be, you need to identify the target individuals. And then it's about adding programs incrementally. It's about saying, okay, we're going to start with these 2 diseases. In 9 months, we're going to add 3 diseases. So really understanding that incremental approach to deploying these technologies and these programs. I'd like to close the sort of formal comments with the essential guidance. And the essential guidance here is accountable care is growing. It has a future. Get involved now. As I said earlier, fail fast, fail often. Accountable care exists in many forms, and it will only continue to grow in its development of new and successful ways of reaching the triple aim. Don't go it alone. Accountable care, especially sustainable accountable care, is really going to require an ecosystem. Carefully evaluate your organization's capacity to digest these new requirements. As I mentioned earlier, it's about change management. It's about your organization's ability to be agile, to be flexible. And it's about managing all this change and what are you going to do, what are you going to implement to help you manage that? Because you're going to be hiring new people with new domain expertise. You're going to be re-engineering your processes, investing in new technology, and really transforming care delivery workflow. Remember, accountable care and population health management is a journey. I wish you all the best in that journey, and I encourage you to get involved as soon as possible. Thank you. Keith, I wanted to start a conversation with you about what you're seeing in your Lumeris clients and others that you're talking to in the market, and what are their experiences around accountable care, what are their priorities and so forth.
Sure, Cynthia, thanks for that, and thanks for all your insights in the presentation. Because I'm really interested in how very early in the journey you mentioned about data and sharing the data and sharing that out with the providers. Of course, after you get the buy-in from the organization and look at your skill set. Because really, it appears that we're at a point where there's a perfect storm in that, as you mentioned earlier, those foundational systems are really in place now to provide that data. EMRs, while not perfect, are now sharing out data more. The payers have a greater willingness to share that claim data. You know, technology is at a point where we have cloud-based platforms that allow anybody to access the information wherever they are, provider office, hospital settings, all those different settings. So it really makes that first step on the journey of sharing the data that much easier. And I really also liked your comment about focusing on the low-hanging fruit. Just as an example, we were talking with one provider group who had a very well-established EMR that had been in place for a number of years, was working very well. But they said, you know, really the one thing that I would like to see, well, it's actually 4 things, but what I would really like to see in the EMR are things like how many times did this patient go to the emergency room? How many inpatient admits were there? How much does this patient cost? You know, if you're in a risk-sharing agreement, I'd love to know how much this patient has cost so far, and then maybe some kind of benchmark about how much should they be costing. You know, very basic information, but it's not available in the EMR. It's the type of information physicians want to see when they're dealing with kind of the total health of a patient.
We're seeing.
Go ahead.
Some interesting work being done to support that point of care. You know, the whole notion of gaps in care, identifying those gaps and then addressing them, you know, can't be done with a single source of data because people see multiple settings. I mean, no one knows that I had a flu shot because I had it at CVS, not in the doctor's office. So really getting that greater perspective and being able to provide that data at the point of care so that the physician can say, look, you need to go get your A1C done, and I'm going to place the order in the EHR, is really kind of the one of the directions that I think we need to be moving as an industry, because we need to take advantage of every opportunity to support those clinical improvements. And it's a shame not to take advantage of the clinician-patient visit to reinforce care paths or behavior changes or whatever needs to be reinforced. So I think that that makes a tremendous amount of sense, and I'm glad you're seeing that in the market as well.
We definitely are. And, you know, an example where we've had with one of our clients is where we were able to deploy our solution, and just by sharing out that data, engaging the physicians, able to see a reduction in ER visits, acute admits, you know, all those kind of metrics that you want to reduce down. But I also found it interesting that you made the statement a few times that it's, you know, really more than just the data. You know, just throwing the data out there doesn't do it. You need the processes, you need the people, you need the intent to get there. So, you know, physician engagement, that's a big part of this.
Right. I would agree with you. And, you know, physicians are basically data junkies. I mean, you know, that's kind of how they think. You know, what's the normal range, what's not the normal range, what do I need to do about it? So it makes sense that serving up that data is going to be really an important part of this journey. Any other observations that you've had working with clients or prospects? What kind of, are there any themes about sort of the challenges that they face?
Well, and you know, like yourself, being more of a technology person, a lot of the challenges is getting access to that data and bringing it together. And then it's, you know, we're seeing the data sources improve over time, but now we're trying to aggregate all that data together. And then we're getting so much data now, how do you shuffle through that and identify those key pieces that you then want to turn around and push back out? Because we've got, if we pushed all the information we have out to a physician when they're sitting across from that patient, they would never get through it all. You know, so now, and you even mentioned that about the analytics and working through that, how do you identify those key pieces and push those out?
And I think that's one of the learnings that we've begun to identify, which is, you know, incremental steps. You know, if gaps in care are part of your priorities, start there. But you certainly don't need every vital sign reading from a stay in the ICU, for example.
Exactly.
But I would agree that the data has been the sort of theme of challenges that I've spoken to many organizations about, and many have underestimated the work that needs to be done to get the data both in a usable format and, as you mentioned earlier, to integrate those together and really make it important and to support decision making. So don't underestimate the level of effort that's going to be required to take a look at and get your data ready so that you know you are identifying the right people and you know that your performance measurements are accurate. So it's all about the data, I think, at this point.
Right, and there are also some non-technical issues around the data as well, since we're starting to have organizations share data where, you know, traditionally providers didn't want to share data with payers and payers didn't want to share it with providers, but we're now bringing that data together, you know, and those are really non-technical issues, but it's things that we need to work through as we move forward on this journey.
Yeah, and also kind of my last comment is really about being prepared to make necessary changes to mitigate those data quality issues or to make that integration easier. It's not just, oh, poor documentation. It's like, so what are you going to do to improve documentation? So it's really a convergence of the data issues and the process issues that drive good or bad data. We have about 10 minutes left, and I thought perhaps we'd open it up to questions. I think people have been sending in questions.
They have. Yes, thanks, Cynthia, and thanks, Keith, for those formal remarks. So at this time, we'd like to welcome the audience to use the questions function on the right-hand side of your screen to submit a question to the speakers. And we actually have had quite a few coming in already. So I'm going to go ahead in the interest of time and launch those. So the first one is, are either of you seeing the quality of data improving? So maybe Cynthia, do you want to start with that one?
Sure. Yeah, I think it is improving. And I think the more we recognize the importance of the data, the more it becomes viewable, the more transparent we are about it. There is motivation, and what's at risk if we don't have good data, then the quality will improve. It's like back in the 80s, I guess, when CMS started to reimburse hospitals based on DRGs. What had been a basement function for medical records, transcriptionists, they were sitting up at the CEO's office because now what they did had financial implications. And as we understand those financial implications, there is motivation and incentives to improve the quality of it. But it's not a short-term process. I think it will be an ongoing process.
Okay, the second question coming in, I'll lob this one over to Keith. What kind of data are most critical?
And I would say, when you're looking at it, you're looking at both what we would call administrative data, which is coming from the payers, and then the clinical data, which is coming from the individual EMRs, labs, pharmacies. As a foundation, I would say that the claims data is very critical, because what that provides you is that holistic view of what's occurring with the patient. I often give the example of going to Florida and playing golf and breaking my foot. The way that that's going to get into the system is through the claim, most likely. Now, that's not to diminish the importance of those other sources, because really, Cynthia, you made the comment earlier about how, as we gather more data, it allows you to be more precise. So the claims kind of gives you that foundational holistic view, but it's really as you add the other data to it is where you get that really useful picture of what's going on with that patient.
Okay, lots of questions coming in via the chat functionality here. One of them is, what is my first and most important investment in population health? So where do I start? With a strategic plan, technology, care teams, physician engagement, or patient engagement? Cynthia, what would you say?
All of the above. No, I mean, I think the first thing you need to do is understand who you're managing and what their issues are. It makes no sense to start investing until you have a strategy. So I would argue that the first thing you need to do is create that strategy and then execute on it. And I think the first place to execute is around the analytics. Most of what I see in the market today ahead of analytics, or behind analytics, I should say, are the care paths development and the patient engagement. I think until you really understand your population, you can't design programs and therefore generate care paths, and until you understand your population and what you're going to hopefully enroll them in, the patient engagement is not very useful. So I think it's, in my mind, always strategy first, understand the data. So the first investment could be in just the analytics, although I believe that's really short-sighted. And one of the challenges we're in the market today is the fact that many of the pure play analytics vendors in the market have created population health analytics, but there's no way to take action on that data. So having the workflow and having the patient engagement, while it's not where you're going to start, really sort of completes that long-term vision in terms of investment.
Okay, the next question is, do you think Meaningful Use Stage 3 is all about pushing providers toward value-based care?
It certainly is moving in that direction. Some of the requirements around meaningful use include things like engaging regularly with your patients and communicating with them. having population health or health and wellness capabilities. And all of those lead you to value-based care. It's also part of, are you really using your EHR to the fullest extent possible? That's really the intent of meaningful use. I think the way it's being developed at the stage, it's about moving people towards the, kind of the changes towards the triple aim changes that we've been talking about.
Okay, very good. What do physicians want to see pushed back into the EMR? So Cynthia, I think you mentioned this comment a little bit earlier in the webinar. Is there anything in particular that they would like to see sort of pushed back through clinical data integration?
Well, I think it's really sort of two levels. One is a completeness level. So, if it's been identified that someone's using the ER a lot, that needs to be documented and what the proposed resolution to that is. So I think it's mostly around documentation. The whole issue of alerts is enormously challenging. Many physicians have turned off their alerts because they just got, totally bombarded by them and they get alert fatigue. And I think there are other ways to alert physicians. So I think what they want retained is where there's been a problem and a solution created that needs to be documented in the clinical records. They certainly don't want all the data coming out of the population health management applications. There's enough in the EHR as it is.
The next question is, culturally and organizationally, how do I know if my providers are ready to move to risk?
Oh, I think it's probably about conversation and relationships. The whole notion of being ready to take on risk, what I've really seen a lot of the health plans do, especially the Blue Cross Blue Shield plans, is they're providing technology, domain expertise, nurse case managers, data to their providers to sort of help them on that journey. And I think it's really about knowing what your provider network looks like. There are generally a range of relationships, and I think especially localized health plans have the advantage that they've met and talked to and been part of many conversations with provider groups. And I also think looking at the better performing groups that may already be doing some of this is a good way to begin the evaluation. Ultimately, you want to bring everyone along, but organizations that have already done patient outreach, that regularly communicate with their patients, that make sure that their patients get flu shots and so forth, are all indicators of readiness.
The next question is, how do you see the nursing profession engage in population health management? What role do nurses play?
Well, I think there are a couple of roles. One is sort of the first line delivery of care. I think we underuse nurses in the clinical setting tremendously, especially in the physician office setting. So if I have a fairly simple strep throat, or think I have strep throat, there's really no reason I need to see a physician. The nurses can swab my throat just as easily. And so I think there is a growing role for nurses in the delivery of care. And then there's a growing role for nurses around managing the populations, about having the skills and having the technology to really be the sort of frontline care managers, if you will, that help prioritize patients and do the outreach and make sure that I'm taking my medications on a regular basis. So I think it's both at the point of delivery as well as in the kind of the management of the population, if you will.
Okay, and this is the last question, unfortunately, that we have time for, but it's for you both about how you see patient monitoring or health coaches or telehealth really coming into the picture. So Keith, patient monitoring?
Yeah, I'll take the remote patient monitoring because really where I see that is, again, as we mentioned earlier, the idea of get as much data as you can and bring that data together. That just becomes another source of data. The good thing about that is as you have a scale in a house which is tied in, or a blood pressure cuff or something like that, you're getting continuous data. You're not waiting for that patient to appear at the physician's office once every 6 months. You're able to see that, so you can see trends over time. Maybe a weight increase that with a congestive heart failure patient could be pointing to something bad. So getting that additional data just completes the picture. I mean, that's kind of the top of the data pyramid, and getting the most accurate and timely information.
And Cynthia, health coaches or telehealth, or?
Well, I think we're seeing the telehealth market begin to evolve a bit. I know that there are lots of use cases in rural areas where it really does make a difference, and also in being able to tap resources that may not normally be available to you, whether it's through a specialty network or any number of other places. I think there's a real role in the educating. There's a real role for it in access. And I also think that there is a more active patient engagement, if you will, if people can participate, whether it's through video conferencing or whatever, those discussions. In terms of coaching, I think there isn't a lot of good ROI around coaching, and I'm not sure whether it's because we haven't done a good job engaging patients. I think there is a role for a coach, and the nurse who calls the patient every morning is really coaching them to continue to take the medication. I think there's also a role for coaches in kind of general health and wellness. How do I use my Fitbit? What does it really mean? I think one of the challenges of coaches is that they have not necessarily been as rigid about having care plans and steps. It's a little bit looser than that, and I think that's been one of the challenges. So I think if the coaches become more like the care managers, there's more structure around it, I guess.
All right. Well, that concludes our webinar for today. I'd like to thank everyone for participating. I'd like to thank Cynthia and Keith for the wonderful presentation, and all of you for your questions. We will make the replay available, and obviously would like folks to download the IDC Spotlight via our webpage, which is learn.lumeris/IDC Spotlight. Thanks, everyone. Have a great day.